Today we'll talk about angiotensin II receptor blockers, also known as Arbs. They are a famous antihypertensive medication that are good because they don't cause dry cough and they don't cause angioedema. With that being said, now let's get started. Renin comes from the kidney, converts angiotensinogen from the liver into angiotensin 1. ACE comes from the lung, converts angiotensin 1 to angiotensin 2. Angiotensin 2 has two receptors, angiotensin 2, 1 receptor and AT2. So AT1 and AT2 are receptors for angiotensin 2. Just because it says AT1, it doesn't mean angiotensin 1. No, it means the number 1 receptor for angiotensin 2. Please don't forget that. And the angiotensin 2 does all of this crazy butt stuff. Also, ACE inhibits bradykinin formation. Even if it's formed, it's gonna degrade it into inactive, ugly, useless metabolites. Okay, now, ACE inhibitors used to inhibit these enzymes. They used to increase bradykinin, causing dry cough and angioedema. Not with the angiotensin 2 receptor blockers, which is today's video, the famous Arbs. They are angiotensin 2 receptor blockers. Do they block AT1 or AT2? They block AT1 of the angiotensin 2. Again, AT1 of the angiotensin 2. Okay, if normally angiotensin 2 will lead to hypertension and increased sodium reabsorption, hypokalemia and alkalosis, what do you think angiotensin receptor blockers will do? I'll tell you. They will treat hypertension. They will increase natriuresis, which will treat hypertension as well, and they will cause hyperkalemia and acidosis. When should you use angiotensin 2 receptor blockers? Hypertension, CHF, diabetic nephropathy, and vascular disease such as atherosclerosis, aortic aneurysm, and Marfan syndrome. We have talked about high molecular weight kininogen leading to bradykinin causing all of this stuff. Is this involved in angiotensin receptor blockers case? No, it's not. So let's forget about that. High molecular weight kininogen will be converted into bradykinin. When you use ACE inhibitors, you will have lots of bradykinin causing dry cough and angioedema. But when you're using angiotensin receptor blocker, forget about this. It's not going to happen. Alright, you don't have increased risk of dry cough or angioedema. Doesn't mean like 0% of cases. Of course there are some cases, but it's not as relevant or as prevalent as using ACE inhibitors. Do you think bradykinin is going to be specifically relevant when you use angiotensin receptor blockers? No. Side effects of ACE inhibitors, as we have discussed in the previous video, we have dry cough, hypotension, angioedema, renal impairment, natriuresis, acidosis, and hyperkalemia. They have dry cough, they have angioedema. Fast forward to angiotensin receptor blockers. They will not touch the ACE, so bradykinin is normal, it's not increased, you're not going to have dry cough or angioedema. However, you're still going to treat your hypertension, it still can damage your kidney, and you will have other symptoms such as natriuresis, hyperkalemia, metabolic acidosis, and please add orthostatic hypotension as well as dizziness. So side effects of Arbs, we have hypotension, renal impairment, natriuresis, acidosis, hyperkalemia, orthostatic hypotension, dizziness, rash, dyspepsia, abnormal liver function tests, and insomnia. You can make me happy and make grandma happy by getting my 50 hematology cases. You can get them by going to patreon.com/medicosis. These cases are awesome. I mean, come on, guys. Example of angiotensin 2 receptor blockers. They block the AT1 of angiotensin 2. Cool. They include anything that ends in sartan. Losartan, valsartan, candesartan, irbesartan, azilsartan, olmesartan, and telmisartan. Who named these things? So, in brief, not boxers, angiotensin 2 receptor blockers block the AT1 receptor of angiotensin 2. AT1 of angiotensin 2. They do not inhibit ACE. Therefore, they do not inhibit bradykinin breakdown. Therefore, there is no dry cough or no angioedema.